Welcome to the Learning Lab. My name is Roman Garcia. What we're going to be discussing today is we're going to elaborate on the biometric protocol that we use to objectify and quantify the individuals that come to us with bow-legged and knock knee. Now, this biometric protocol that we created is probably a year, maybe 2 years old. So we're learning and we're gathering more information as we continue to use this biometric protocol. Now, the idea behind this biometric protocol was to establish objectification when we examine an individual, because we wanted to know where we were at baseline and then compare the baseline to the post-treatment effect. So we needed a way of objectifying and not just relying on subjective reporting from our patients, which is how it's usually done in the rehab centers, which we've always felt that was not productive to the advancement of treatment of individuals who have bow-legged and knock knee. So anybody that's seen our videos before is already familiar with this biometric protocol. So I want to show you one particular case and elaborate further on this biometric protocol. So anybody who sees this video and is interested in learning how to perform these evaluation process can very easily learn it by just contacting us. But first, let me just go over again the biometric protocols and be a little bit more specific as to what these figures mean that we use in our protocol. Now, I want to show you first the schematic on what the biometric protocol entails, and I'll show you later on this case that we just saw recently. Now, you're going to see a vertical line going straight down the knee on an x-ray. You're going to see it on the right, and you're going to see it on the left. We call this line a directional line. A directional line. A directional line. These are directional lines. Now, the reason we call them directional lines is because it pretty much tells us which way the knee is heading into, either bow leg or knock knee. Now, these pyramid or right triangles that you're going to see on the x-rays, printed on the x-rays, give us the magnitude. This is the magnitude triangle. The magnitude triangle. This pretty much tells us the magnitude of load that either the inside or the outside of the knee is being exposed to. Now, these triangles are not as intuitive to understand as they seem to be, and I'll show you in a little while what I mean by that. Now, I want to show you a particular case that we saw not too long ago to emphasize one of the data points that this biometric gives the examiner and how important it is for objectifying these bow-legged or knock knees. Now, this is a case that we saw recently. What you see here is two knees. You see the right knee and you see the left knee. So this is the right knee, and then this is the left knee right over here. This is the cartilage space right here. You can see that this individual has quite a bit of cartilage still in the knee. Now, this individual came to us with pain in both knees, but one knee had more pain than the other. The left knee had more pain than the right knee. Now, just from observing it here, you really cannot tell if this individual is knocking or bowing, whether they're knock knee or bow legs, unless you use this biometric protocol that we created, that we established. Just by observing, you cannot tell. And you could not tell just from observing the patient from the perspective of somebody facing another individual and observing them from the front. So again, we saw this individual. We weren't sure whether they were bowing or knocking until we did the biometrics. And then the data started pouring in. Now, this is the biometrics labeled on top of the x-rays themselves. Now, again, this is the directional line. This tells us in what direction the knee is heading, whether it's heading towards bow-legged or knock knee. This directional line, when it starts crossing the inside, it tells the observer, the examiner, that this individual is going into knock knee. Now, it wasn't This is not coincidental because we see this pattern over and over again. The knee that was hurting her the most, that was hurting this patient the most, the directional line was going further into a knee that's in a knock-knee posture. Now, the interesting thing about this x-ray is that when you see the magnitude triangles here, the knee that's in a further knock knee, which is the left, the triangle is smaller relative to the less involved knee. Now, in an individual who is going into a knock knee and whose directional line is telling the observer that it's in a knock knee, in the majority of the cases, you would expect, intuitively, you would expect that the triangle should be larger, because if they are in a knock knee, their weight-bearing convergence is always going to be more on the outside of the knee. So you can see it that on the right knee, that holds true to the theory. The magnitude triangle is larger than the triangle on the inside. So is on the more involved knee. The outside triangle is slightly larger than the inside magnitude triangle. Now, the interesting thing is that intuitively you would think that because this knee is going further into knock knee, that this outside triangle angle should be larger because there's more weight-bearing load on the outside part of the knee. But the interesting thing is, the paradox is that because the knee is going in further into knock knee, she's experiencing convergence of stress over a smaller surface of the knee. So in other words, the weight-bearing load are equals on both knees, yet the outside part of this left knee is experiencing convergence of stress. She's being exposed to the same amount of weight-bearing load, yet a smaller surface area, which means where that small surface space that's exposed to the same amount of weight as is the right is being exposed to greater weight-bearing load. So we know from this biometric protocol, this quantification of this x-ray, we know that this left knee on the outside part of the knee is experiencing tremendous amounts of weight-bearing load over a smaller surface area. So what we need to do is we need to expand this magnitude triangle. We know that our protocol, our intervention is working when a post x-ray is done again and we create these magnitude triangles again. As the knee gets healthier, this outside triangle will start to get larger, meaning that the surface area is expanding and contributing to tolerating the weight-bearing load. In other words, more surface area, same weight, less pain. But this is a way of objectifying it. Now, what I'm going to do is I'm going to show you a case, a real-life case here of how these loads will be exposed in a living individual with the help of my assistants here, Anna.
And hello, everybody. Hi.
Anna, she's going to sit right over here. Siéntate aquí. Now, we know that Anna is she's knocking. She has knees that knock knee. We've established this in the past. Now, for Anna, it would be normal in a knee that's tolerating the knock knee without any symptoms, without inflammation, for the weight-bearing load, the biometric, would look something like this. It would be, this is the directional line. She's knocking, so we know that the line is gonna direct itself on the inner half of the knee. So we would expect that we established this already. The magnitude triangle on the outside of the knee would be larger than the magnitude triangle on the inside part of the knee, because this is the normal pattern that you would see in a knock knee. The magnitude triangle on the outside will always be larger than the magnitude triangle on the inside part of the knee. Now, if Anna was to experiencing a degenerative event, and she would be symptomatic, and the knee would be in a degenerative descending trend, we would probably see, if we compare both x-rays, we would see her magnitude triangle on the involved knee would be smaller relative to the uninvolved knee, because the weight-bearing surface as the knee degenerates gets smaller. In most cases, not in all cases, but that's the pattern that we've been seeing. So if Anna would be in a degenerative state, our objective would be to expand this magnitude load, the magnitude triangle. So more surface area is contributing to the weight-bearing condition of the knee. Now this is what we would want. This is what we would see on an asymmetrical joint or condition, where one knee would be in a normal state and the other knee would be in a degenerative state. The magnitude triangle will be smaller. Now this is what we normally see. Ana, párate. So this is how it would look when she's standing. Standing, she has equal weight-bearing loads on both knees. This uninvolved knee, this is theoretical, but this uninvolved knee, the outside part of the knee, because the magnitude triangle is larger, her weight, more surface area is contributing to tolerating or maintaining the weight-bearing load symmetrical, whereas in the involved knee, the magnitude triangle would be smaller. Thus, equal weight, more surface area here, exposed to the weight-bearing load, but in this area, in the involved lateral compartment, the triangle would be smaller. Thus, surface area would be smaller, yet tolerating or being exposed to the same amount of weight-bearing load, which would be going straight down. Smaller surface area, more per inch weight-bearing load requirements. Thus, the tissues will become symptomatic and inflamed because they cannot tolerate the weight-bearing load. It's not being distributed equally between both sides, the inside and the outside. And since she's not knee, most of her weight-bearing convergence is going to be laterally. Te puedes sentar. So, this is what we see. There has to be changes in the medical community when it comes to treating knees. Knee issues is an epidemic in today's society. I believe there's over like 200,000 individuals alone that have knee replacement surgeries in the United States. It's a lot. The knees are the most susceptible joints to develop degenerative changes. It's very rare that anybody gets past 40 or 50 years old without experiencing knee issues already. Knees are something that people normally take for granted. So they expose their knees to stress and activities that contribute to degenerative changes in the knees. And most times, there's always a cause to these degenerative changes. Now, the medical community has not developed proper protocols, evaluation protocols, to evaluate individually, uniquely, individuals and their knee conditions. And this is why we are far superior in being able to evaluate and pinpoint and address the issues. So most of the patients that we work with, actually all of the patients that we work with, respond, because we're able to identify specific areas of the knees that are the ones that are contributing to the symptoms and the dysfunction. But unless you're able to develop a biometric protocol which can objectively identify these spaces in the knees that are contributing to the symptoms, then the individual gets treated as everybody gets treated. And the truth is that every knee issue that comes to us has some unique qualities specific to the individual's history. So if anybody watches this video, any professional watches this video, they're interested in learning these biometric principles, we will share our knowledge with you. And furthermore, anybody that has knee issues or concern with their bowing and their not knee and they want to find a remedy to the problem, please contact us. Our information of contact is always there on the videos. So for anybody that watches this video, we want to thank you. Until next time.